Hello everyone, and welcome to this lecture on oral potentially malignant disorders. Now, this lecture will be conducted as a joint lecture wherein you will notice that some components of the topic are discussed by me and some other components are elaborated by Dr. Larry. So this is a total of two lectures that have been combined together. So the learning outcomes for this topic under the DTS curriculum are as follows. By the end of the topic, the student should be able to define and classify potentially malignant disorders or oral potentially malignant disorders. Second is explain the etiology, clinical and histopathological features, differential diagnosis, and management of OPMDs, which is oral potentially malignant disorders, under which mainly we would be stressing on leukoplakia, lichen planus, and oral submucous fibrosis, which is abbreviated as OSMF. The first thing that I want you to reflect on is how do we see color, right? The reason I am asking you this question is because of the name of the topic. If you look at the topic name, it says red and white lesions of the oral cavity. So that means we're trying to categorize the presentation of certain lesions based on the color, right? So how do we see color? So just to recall something that you learned in optics as part of your physics, maybe in foundation or in early years, right? White light is composed of different wavelengths of light, right? Which when mixed together actually produces the white light, and this white light is composed of seven different colors, right? So if there is a red color that we are able to visualize, okay, like for example this apple over here, it means that when this white light falls on this red apple, it actually absorbs all the other colors of the components of the white light but reflects only the red, and that's why we're able to see the red line. Okay, so this same laws of physics or optics actually apply to all the other colors as well. All right, so we're able to actually see black. Anything that is black, physically black, is because when light falls onto it, that particular object or that particular color actually absorbs all the wavelengths and there's nothing that is reflected black. Red, as we just discussed, and white is when we see the entire color of the light that is reflected black. Now, this is very important because this is what is the physics behind how we see color. Now, we will see how this also leads us as dental students, as dental surgeons, and as oral health practitioners to be able to categorize different colors of lesions that we actually see, mainly white and red lesions over here. Okay. Question now is what factors affect the color of the mucosa? So number one is obviously vascularity. Okay. Now here is a picture of a patient who had a lesion on the tongue. You can clearly see that this entire thing appears normal, and here there is a bluish reddish lesion on the surface of the tongue. Okay. Now the reason we are able to see this is because there is increased vascularity. So that means what I'm trying to make you understand here is that if this is the clinical appearance, if we would do a microscopic examination of this piece of tissue, what would we see? And what we see under the microscope, how does that relate to how the lesion appears clinically, right? So we're able to see a red and bluish appearing lesion on the tongue because microscopically there are large big blood vessels that have stagnant blood in them, right? So as we know, when there is stagnation of blood, there will be it will be composed of mainly deoxygenated blood, which appears bluish reddish in color, and that's why the reddish hue clinically that is visualized. Okay, so number one factor that affects the color of mucosa is vascularity. Second is melanin pigmentation, right? So we are familiar with the term oral melanotic macule, and if you look at this picture here, you're seeing a brownish pigmentation on the lower lip. If we actually do a biopsy of this particular piece of tissue, this is how it's going to look, and you can see that there is increased expression of melanin pigment in the basal layer, right, giving it the brownish color appearance. The third important reason why you see a change in color in the mucosa could be keratinization. Alright, so when we say keratinization, it appears as a whitish lesion on the mucosa, right? And this whitish lesion that you're seeing on the gingiva in this particular picture, if we correlate it with the biopsy that we do, then you will notice that there is this pink layer of keratin that is produced on the surface of the epithelium, giving it that additional thickness because of which the light cannot penetrate in and is entirely reflected back, right? So this is how we would actually apply the laws of optics here to be understand why we are able to see a white lesion, right? So here in this case, this lesion is white because of increased keratin that is produced on the surface. Right. Another reason for increased or for a lesion to appear white is because of the epithelial thickness. One reason of increase in epithelial thickness is because of overproduction of keratin on the surface of the epithelium, which I just mentioned is called hyperkeratosis. Another reason why when epithelial thickness actually increases is when there is epithelial hypoplasia. Okay, so you have to understand that epithelial hypoplasia is when the number of cells increase in the layers of the epithelium without production of keratin on the surface, right? So this is the difference between hyperkeratosis and epithelial hypoplasia. So in either condition, what is happening is that the white light is finding it difficult to penetrate in and thus is reflected out. Okay, so because the entire wavelength of light is white light is reflected back, we are able to see these clinical lesions as white lesions. Okay, right. So just to recall how normal epithelium looks, this is how it looks, right? So normal stratified squamous epithelium of the in the oral cavity, right? You're seeing these retipex, right? You're seeing the basal cells that are arranged, the spinous cell layer, the regular stratification here, and the surface layer. This is how it looks, right? Now to compare that to an atrophic epithelium. Now this is what is described as an atrophic epithelium. That means the thickness of the epithelium reduces, right? There is a loss of rete ridges, the thickness reduces, thereby increasing the amount of light that is able to penetrate through the epithelium and refract the underlying color of the connective tissue to us. Okay, so I want you to understand that a normal epithelium histologically will clinically appear like this, right? Whereas an atrophic epithelium, as described here, will actually give us a reddish lesion, right? That means the thinning out of the epithelial layer leads to the underlying connective tissue and contents of the connective tissue giving the reddish hue clinically. Okay, so with this background, you will be able to understand red and white lesions, uh, the reasons for why a particular lesion appears red, why a particular lesion appears white. Okay, and as we go along, you will be able to understand that what is the importance of these colors, okay, or these lesions in terms of us being able to predict the outcome, to be able to predict the prognosis of the disease. Okay. Right, so let's first look at the possible causes of keratosis. Okay, so histologically, I've tried to tell you that keratosis, if it's taking place, it means that there is an extra layer of keratin that has been produced on the surface of the epithelium, but there could be a lot of reasons for which this keratosis can take place. So I'm going to run you through this because this is important as part of the first learning outcome, which was to be able to categorize the causes of red and white lesions. So here we're going to look at the white lesions, causes of white lesions first, right? So number one is traumatic. Okay, so they could be trauma, mechanical trauma, okay, as in let's say a sharp denture, a sharp tooth, okay, which constantly causes irritation of the mucosa, giving rise to a response where there's production of keratin and it appearing white to us. Okay, the second reason could be chemical, for example, aspirin burn, all right, or number three could be thermal, right? For example, a pizza burn. okay, or any hot liquid that a patient actually has that causes trauma here, and this trauma actually leads to sloughing of the epithelium, thus increasing the thickness and thus making the lesion appear whitish. Okay, the second cause could be categorized as infective. Under that, you have candidiasis, which is a fungal infection. You have oral hairy leukoplakia, which is caused by Epstein-Barr virus, and you have syphilitic leukoplakia, which is caused by syphilis, okay, a manifestation of syphilis. Under the hereditary causes, you have white sponge nevus, we have genodermatosis, a category of disorders collectively called genodermatosis. That means they are genetically they're genetic disorders which are hereditary, and they cause skin as well as oral lesions which appear white. And of course, leukoedema, right, which is again hereditary but is not a pathology and is categorized as a normal variant. The next is dermatological causes, for example, Lichen Planus, which is a condition that affects the skin as well as the oral mucosa, okay, in which there could be white lesions or red and white lesions in the oral cavity. Lupus erythematosus, another skin lesion which has oral manifestations, wherein we could see keratosis. And of course, neoplastic, that means carcinoma in situ or squamous cell carcinoma, also present as white lesions or keratosis. And the last is idiopathic, which is called leukoplakia. Now I'm going to discuss leukoplakia a little more in detail further on in this lecture. Okay, but the aim of this slide is to make you understand that these are the various categories of causes for keratosis in the oral mucosa. Okay, now moving on to the concept of oral potentially malignant disorders. Now, first of all, I'd like you to pay attention here because this is a very important core concept. Okay, and there is a little historical background to it. Before 2005, okay, before 2005, um, many oral lesions were categorized as pre-malignant lesions or as pre-malignant conditions. Okay, but after 2005, the World Health Organization recommended a nomenclature wherein they clubbed both the pre-malignant lesions and the pre-malignant conditions together to be able to call them as oral potentially malignant disorders. Now, the reason why the WHO recommended this new nomenclature is because both pre-malignant lesions and conditions. Okay, first of all, what are pre-malignant lesions? Pre-malignant lesions are basically any lesions that some lesions that when present in the oral cavity have a high chance of turning into cancer. Okay, whereas pre-malignant conditions is a condition of the entire body of the person wherein his oral cavity is at a higher risk of developing malignancy. So what the WHO did is, instead of having these two categories, they actually merged them together to call them that if a person has any of these disorders, whether they are specific lesions or the overall condition of the body, then it is called oral potentially malignant disorder, or that means that this person has a high risk of developing oral cancer at some point. Okay, so this is very important, and the reason why I stress this is because if many of the textbooks still do not actually mention oral potentially malignant disorders and are still categorizing them as malignant and pre-malignant lesions and pre-malignant conditions, but we would want you to use the newer terminology and follow this up. I do understand this is already more than 10 years old, but unfortunately this is how it is in some books. Right. So oral potentially malignant disorders, also abbreviated as OPMD, is defined by the WHO as the risk of malignancy being present in a lesion or condition either at the time of initial diagnosis or at a future date. Now, under this OPMDs, these are the 10 listed lesions or disorders that have a high chance of developing oral cancer in a person. So number one in them is leukoplakia, erythroplakia, palatal keratosis associated with reverse poking. Number four is cytopenic dysphagia, lichen planus, oral submucous fibrosis, syphilis, discoid lupus erythematosus, xeroderma pigmentosum, and epidermolysis bullosa. So now in this lecture, some of these topics would be covered by me, and in some of these other topics, you will notice that Dr. Larry would be elaborating. Okay, so let's move further. Okay, so this slide here shows us the histological changes that take place between normal epithelium to hypoplastic epithelium to dysplastic epithelium and then to cancer. So this is the core concept behind oral potentially malignant disorders. That means disorders that have a tendency to lead to oral cancer in the oral cavity. So this is the histological understanding of that concept.
So let's start with oral leukoplakia. You're very familiar with oral leukoplakia as a predominantly white lesion of the oral mucosa that cannot be characterized as any other definable oral lesion. Having said that, sometimes the diagnosis or clinical diagnosis of oral leukoplakia can be quite challenging, as for novice practitioners or dental students, it might mimic other lesions and you may tend to either overlook it, miss it, or probably diagnose it and yet not be able to convince the patient to be on regular follow-up. The reason why I'm talking about that is because oral leukoplakia is a potentially malignant disorder with a global prevalence of 2.6%. Now this looks like a very small number, but then it is that number that we want to catch early so that they don't turn out to become malignant, and we don't want to see many patients coming back with malignant lesions, right? So it's of utmost importance that you catch these and treat these patients early. So generally the male predilection is higher than female, and most of the patients are over 50 years of age. When it comes to site, in case of non-smokers, the most common site is the border of the tongue. We don't really know the reason why specifically it is this lesion. This lesion is seen in this particular area. And when the lesion is seen in any patient, either smoker or non-smoker, on the floor of the mouth, lateral border of the tongue, it carries a high risk. And this high risk is because of high malignant transformation rate seen in these particular areas. Now the reason could be because of blood supply. But what is to be importantly noted is when a lesion is seen in these areas, it should be immediately biopsied and taken care of. There are different types of clinical classifications of oral leukoplakia. The homogeneous one, which appears like cracked mud; non-homogeneous, also called as erythroleukoplakia, which I find is a very confusing terminology. So more preferred and easier to remember one would be the word speckled leukoplakia. The reason why we use the word speckled is because it could be nodular, papillary, exophytic, or simply a mixture of red and white. And the third one is a proliferative verrucous leukoplakia, PVL, which is a more aggressive form of leukoplakia, having a higher malignancy rate and recurrence rate. This is homogeneous leukoplakia. You will notice that there is a white lesion here, which is non-scrapable, and having this crack-like appearance, which is what is similar to or considered as cracked mud appearance. Now, if you observe this first picture here, you will notice that there are thinner areas of the lesion and thicker areas of the lesion. Now, does that mean that the thinner area is having lesser rate of malignant transformation and the thicker one? Well, you can say so. If this thicker one becomes further thicker and exophytic, then definitely it would move on to become a non-homogeneous type. The non-homogeneous leukoplakia again may generally arise from a homogeneous variety, where you're seeing a white area and along with it a mixed red and white area. Now again, these are non-scrapable. You also see a pigmented variant here, but this is less problematic than this one circled in yellow, and hence this area should be the one where the biopsy should be taken from. Similarly, on the commissure area here also you're seeing a more extensive red and white mixed lesion, which is looking very suspicious and must be biopsied instantly. The PVL is more exophytic. It is considered could be a precursor variant of the verrucous carcinoma. And these are known to be very notorious because of aggressive nature, widespread, and recurrence rate. Now in this picture of the palate, you will notice that there is a thick exophytic area, there is a thinner area, and of course there is a red and white mixed area as well. The clinical features of proliferative verrucous leukoplakia are the first of all the varicose papillary projections, which you can see here in this picture that is posted here. They're more aggressive, have a high recurrence rate, and predilection for older women, and lower gingiva. So this image is also that of lower gingiva, and have a high malignant potential. On the other hand, erythroplakia is a red lesion of oral mucosa that cannot be characterized as any other definable lesion. The global prevalence is much lesser. It has well demarcated borders and is asymptomatic. This is also a potentially malignant disorder, carrying the highest risk of malignant transformation among all of the pre-malignancies. There is a special form of erythroleukoplakia associated with reverse smoking of chutta. This is an example, which is restricted to some certain tribes in southern India, where they place the reverse end of the smoking, the reverse of the smoking end, burning end in the mouth, and hence obviously because of heat and tobacco itself, it leads to lesions which are quite ugly looking and red and velvety. This is a classical appearance of red and white or erythroplakic lesion, extremely velvety and red. So this carries a very high malignant transformational rate, especially the one seen on the tongue over here, or the buccal mucosa and the palate again. Right, so these images occur to see the International Association of Cancer Research, and it's quite rare to find erythroplakia and give erythroplakia, pure erythroplakia, as a diagnosis in a clinical setting. Even if you are giving this diagnosis, you should be very cautious and very sure that you're looking at an erythroplakic lesion. Mind you, again, let me remind you that majority of the time, even though it is so red, these lesions are asymptomatic. So the patient doesn't perceive pain and hence tends to postpone treatment or evade biopsy. So this again flowchart is very commonly used. This is by Van der Waal, which gives you an idea of how to actually manage oral leukoplakia or manage a white lesion. Now this is a very skeleton framework of the table. If in case you are given a scenario or asked a question, how would you treat or manage white lesion, then you might want to make changes accordingly and modify this table. So let's just look at this table once. Provisional clinical diagnosis. Let's say you've come up with a diagnosis of oral leukoplakia, and how do we go about this case? So first of all, you try and eliminate the possible cause. Now what could be the causes? Either ask your patient to quit smoking, or if there is a sharp tooth or any denture that is irritating the area, you would want to eliminate that cause. I mean, when you're suspecting a white lesion, you would obviously look at the surrounding, what are the areas surrounding the white lesion, what are the heart tissue structures surrounding the white lesion, and you would want to look at it, is there any reason for suspecting, not suspecting leukoplakia. If it looks very clear like leukoplakia, and you do not get any response even after the patient has not quit, then you know that you're looking at biopsy as a diagnosis, or you have another diagnosis which is not looking like leukoplakia. If the patient has responded well and you know a definable lesion, that means you have probably a frictional keratosis, let's say, and then there is a sharp tooth. Might be enamelloplasty has solved your problem, and hence you can manage that by doing the enamelloplasty or changing the denture, if the denture is the reason why there is a white keratotic area there. On the other hand, if you're not able to find any possible causes, why is the patient having a white lesion? Let's say he or she doesn't smoke, or it's a female patient with no known family history or no known habit history, and you are not sure of what clinical diagnosis to arrive at, or you're sure and have a definite clinical diagnosis, then you would, either ways, you would want to biopsy the patient, right? So when you biopsy the patient, you will come up with either no definable lesion again, that means in favor of leukoplakia, right? And then you will look for either it having dysplasia or no dysplasia, right? On the other hand, you biopsy it and it turns out to be some other definable lesion. That means, for example, it turns out to be Lichen Planus, or it turns out to be a morsicatio, that means cheek biting, then you know how to manage it accordingly. In case you don't have a histopathological diagnosis for it, it is perfectly falling into your criteria of oral leukoplakia. Again, let me remind you that oral leukoplakia is actually a clinical diagnosis. So on histopathology, you would either call it as keratinization, or areas with hyperkeratosis, or you're seeing dysplasia. When you're seeing dysplasia, again, it is important to note down the type of dysplasia that you're seeing, mild, moderate or severe, and manage this patient based on the type of dysplasia that you're seeing. Of course, follow-up and observation of this patient is very important. Long-term follow-up with 3 to 6 months follow-up if in case it's just mild dysplasia, and then observe, and if in case it ends up being moderate to severe dysplasia, then sometimes you might need to follow up these patients at a 3 to 6 months interval for nearly a lifetime of follow-up. So when we're talking about management of oral leukoplakia and erythroplakias, we should keep in mind that the malignant transformation of oral leukoplakias are about 1 to 20% over a period of 1 to 30 years. So it's very difficult to give answers to your patients that how soon will my white lesion become cancer? It's a very difficult question to answer for the clinician. So the only thing that you can tell your patient is that if you quit habit, and if you take care of yourself and regularly come for follow-up, then I can probably reduce the speed at which it becomes cancer. But if in case the patient doesn't listen to your advice, then it's very hard to tell how soon that area will become cancerous. There are risk factors which determine how soon or the lesion may turn malignant. We'll look at those risk factors later on in the oral cancer chapter. So in case of erythroplakia, the malignant transformation rate is very high. It's 51%. That means out of the 100 cases of erythroplakia that you see, 51% are sure to become malignancy. So in 60 to 80% of all squamous cell carcinoma cases, they are preceded by an oral potentially malignant disorder. So that is something very important here. That means in 60 to 80% of the cases of all squamous cell carcinomas, had a dentist seen them when they were in the stage of oral potentially malignant disorder, we could have actually saved the patient from turning into oral squamous cell carcinoma, or at least prolong their lifetime by reducing risk factors. So discontinuing habit is still a very, very important part of management. There is smoking, alcohol, betel nut chewing, and important to review these patients 1 to 3 months if they're still following the path of discontinuing the habit, or have they hooked on to the habit again. Biopsy is a very critical tool in managing these lesions. First of all, it's a rule of thumb that within 2 weeks of seeing the case or visualizing the lesion, if there are no signs of subsiding, it is important to take a biopsy for the lesion. There are other reasons why you would think that immediate biopsy is important. Is first of all, if your patient seems non-compliant to follow up, if you think that he or she is not going to turn up, and it is important that you make them realize that this lesion doesn't look very good, then it's important you suggest biopsy, maybe at the first or second visit itself. If you do not have an established etiology, that means you're looking at a patient with no habit history or any other reason to suspect why this patient would have developed a white lesion, and you're still seeing a white lesion, you must do a biopsy. And lastly, if the lesion looks suspicious. Now, the reason why I've underlined this word suspicious is there is a tendency for young doctors to think that everything looks suspicious. But it is where do you draw the line? What is suspicious? What is non-suspicious? Now that comes with clinical experience. So what I would suggest that you look at is, if your patient is having risk factors, you've already waited for 2 weeks, and your patient is probably not following or not falling under any other category, it's important that if you're looking at a red and white lesion, you get the biopsy done as soon as possible, in order to at least have a definitive diagnosis in hand, and in future how to manage the case. So after you have taken the biopsy, and if the lesion is confirmed to be leukoplakia, whether it is having dysplasia or not having dysplasia, it's important that surgical excision or laser surgery is done and the patient is kept under follow-up for every 3 to 6 months. At this point, I wanted to introduce you to the term field cancerization, which means this is a form of cancer which is caused by simultaneous genetic instabilities in the epithelium of several extra lesional sites that may lead to squamous cell carcinoma. Which means that if a patient is having multiple lesions in the oral cavity, multiple leukoplakias at different sites, this patient becomes more susceptible or has a higher risk of malignant transformation. That is important to watch out for.
Now, leukoplakia has a dose-response relationship with tobacco. It is commonly seen in tobacco users. The more you are using either smoked tobacco or smokeless tobacco, there's a high chance of developing leukoplakia. The demographics vary regionally. That means based on the habit of the patient in various parts of the world. There are different areas in the oral cavity that present with leukoplakia. Onset is usually after age 30, and the peak incidence is after 50 years. In the West, there's a female to male ratio of 1:1. In the East, there is a higher male precedence as compared to females. The etiology is multifactorial. Okay, so tobacco, as I told you, has a dose-response relationship. Alcohol acts as an adjunct here. Candida albicans in many cases also causes hypoplasia and leads to a lesion called candidal leukoplakia. Okay, wherein there are hyperkeratotic lesions that are secondarily infected with candida, and sometimes the long-standing candidal infection can cause dysplastic changes as well. Viral agents such as HPV 16 and 18 are also considered to be an etiology. Nutritional deficiency and genetic role has also been identified. So as you notice, leukoplakia is multifactorial. So this is an example of a white patch that is seen on the floor of the mouth. If you look at it, it's very uniform. The entire white color, the color is white everywhere, and so that's why this is homogeneous leukoplakia. Has come to us. We know the background that it's related to tobacco use. We know that this is and could be an oral potentially malignant disorder because we've come up with the diagnosis of leukoplakia. We know that oral potentially malignant disorders have a high chance of developing squamous cell carcinoma or oral cancer. So what are we going to do? We're actually going to do a biopsy. The reason we do a biopsy is to be able to identify cancerous changes early. Okay, the success for us as oral healthcare providers is not to be able to identify overtly looking cancerous lesions, but to be able to identify early lesions, right? Early changes, so that we catch it early, treat it early, and ensure that the prognosis is good. Okay, so with that, what we are trying to look at in these biopsies of these leukoplakias or oral potential malignant disorders is these set of epithelial dysplastic features. Now, I clearly know that in second year you are familiar with this, but we're going to go through these in detail. Okay, because this is the core concept of oral potentially malignant disorders, right? So before I take you further, I'm going to again reinforce. So I've explained to you what is why a lesion looks white, why a lesion looks red, which of them is dangerous, the reason why that is dangerous, and the list of what is oral potentially malignant disorders. An example that we are discussing right now is leukoplakia. Now, leukoplakias can be homogeneous or non-homogeneous, right? Now we're just saying that let's say we have a patient who's come to us who has leukoplakia, and we want to actually identify what is going on microscopically, right? So what are we worried about when we are trying to do a microscopic diagnosis? What we're worried about is, has the patient mucosa undergone any cancerous changes? So when we say cancerous changes, we mean epithelial dysplasia. Okay, right. Now, epithelial dysplasia, we have these 13 features that are outlined by the WHO that helps pathologists and oral pathologists identify epithelial dysplasia. So number one is loss of polarity of basal cell. Number two is basilar hypoplasia. Number three is increased nuclear cytoplasmic ratio. Number four is drop-shaped retipex, increased nuclear number of mitotic figures, individual cell keratinization, irregular stratification, cellular pleomorphism, nuclear pleomorphism, prominent nucleoli, loss of cellular cohesion, and abnormal mitosis. Okay, so in the coming slides I am going to explain each and every feature individually so that you can actually understand them. Right. So the first one is loss of polarity of basal cells. So what does that mean? So this means that when basal cells are not arranged perpendicular to the basement membrane. Okay. Now, if you look at your diagrams or if you remember how you had actually drawn normal epithelium, it was basically you had a line here, you draw the regular retipex like this, right? And then in the retipex you actually draw these basal cells like this, right? I'm sorry, I think we've gone wrong here. So let me try again. Let's say this is the basal cell. What you do is you actually draw the nuclei around here and you make sure that this base is the basement membrane while this is the basal cell. Now if this cell loses its orientation to the basement membrane, that means it loses its alignment, then you call it loss of polarity. Now this is what this particular area clearly shows you. Okay, this is you see this. The second is basal cell hypoplasia. Okay, now this is normal epithelium, right, which I have shown you in my previous slides as well. This is the retipex here. These are the basal cells. Basal cells usually are the first layer, okay, are usually the first layer above the basement membrane, and they have the progenitor cells which actually mature and progress to become spinous cells, so on and so forth, the layers of the superficial epithelium, and then they exfoliate, right? So that's the normal life cycle of an epithelial cell. Now what happens when there is basilar hypoplasia is you see two layers of basal cells. And how do you identify them? You identify them based on their dark hypochromatic nuclei, right? So now if you see a double layer of basal cells, well, that is not good news. It indicates activity in the basal cells, okay, which means that something that's wrong, okay, indicative of a dysplastic feature. The next dysplastic feature is drop-shaped retipex. So what do you mean by drop-shaped retipex? Well, if you notice, this is the shape of the retipex now has transformed to look like a drop, right, like a water droplet. Okay, again, this is taking place because of the rapid proliferation. Okay? Now, if we look carefully, the other features are pleomorphic cells. Pleomorphic cells, the term pleomorphism is pleo means many, morph means morphological appearance. If you look at these cells here, different cells have different sizes and shapes. Okay, which is seen, which is described as pleomorphism and is a feature of dysplasia. Right. This picture here also shows you cells where there is mitosis, and these mitoses are not normal. The reason why this is not normal is this is one cell which is showing a tripolar arrangement of the nuclear material, indicating that this one cell is going to divide into three. Okay, another feature that you notice here is that this is the nuclei. Inside the nuclei you are seeing two nucleoli. Okay, so that is prominent nucleoli. This is another cell over here which you're seeing is undergoing mitosis. Okay, but this mitosis looks like normal, but this is abnormal mitosis. Okay, so all of these are features of dysplasia that can be under the microscope. Okay, so again, mitotic figures, right? You're seeing the chromatin material that's arranged over there, and this is a feature called individual cell keratinization. So if you look at this, when this epithelial cell is showing increased pink color material being deposited, then that is indicative of keratinization that is taking place. So now we have normal epithelium, which is regular arrangement, right? Regular stratification. But in dysplasia, what happens is there is a loss of stratification. That means there is irregular arrangement of these cells as they mature and progress further, which is not good news. Okay, which is indicative of dysplasia, which is indicative of a pre-malignant change, right? That means this part of the epithelium has a higher chance now of going into, right? So epithelial dysplasia reflects abnormality in proliferation, in maturation, and in differentiation, right? So epithelial dysplasia reflects these three abnormalities. Now, once we see these features in the epithelium, we are required to actually again grade it. Okay, it's not just enough to identify these features; it's also important to be able to grade them. So when to grade them, basically, what we do is we actually divide the epithelium into three equal parts, okay, to try and see into which part you are seeing these features. Okay, so if you are seeing dysplastic features just only in the lower one third, then this is mild. Okay, but if you are seeing in lower one third and the middle one third, then you call it moderate epithelial dysplasia. But if you are seeing dysplastic features entirely in the thickness of the epithelium, is that it helps us to convey to the clinician that what exactly is happening, right? So again, I would like to tell you that when you grade epithelial dysplasia, when we see epithelial dysplastic features, we grade them. Okay, now according to the WHO, we can grade them as mild, moderate, and severe. There's another new system that is actually becoming more accepted, which is called the binary system. Okay, wherein you just grade them as low grade dysplasia or high grade dysplasia. So what's happening is mild epithelial dysplasia is considered to be low grade, but moderate, severe, and carcinoma in situ is together being graded as high grade dysplasia. So the reason this change from a three grades to a two grade system is for easy communication with the clinician and to be able to communicate to the patient so that regular follow-up treatment and prognosis can be better. Okay, so the important point here is, now if we have a patient who is identified as having leukoplakia, which is an oral potentially malignant disorder. First of all, leukoplakia is a term we use as a clinical diagnosis of exclusion. Okay, that means you come to this diagnosis only if you have not been able to categorize it as any other known white lesion. Secondly, microscopically, a leukoplakia could be anything between hyperkeratosis, epithelial dysplasia, or squamous cell carcinoma, right? So the spectrum of a leukoplakia, clinically appearing lesion, which is called leukoplakia, could be anything between a banal hyperkeratosis or epithelial dysplasia, any of these grades, okay, or worse situation would be squamous cell carcinoma, right? So what I'm trying to explain to you here is a white lesion or a white and red appearing leukoplakia here could be either hyperkeratosis, epithelial dysplasia, or squamous cell carcinoma. So, okay, we have the clinical diagnosis, we've looked through the microscopic diagnosis. So what about prognosis? What are we supposed to tell these patients? So, well, a proportion of these dysplastic lesions will undergo malignant transformation. It varies anywhere between 1 year to several years, and dysplastic lesions carry increased risk of malignant transformation based on their grade. I'll tell you that. Malignant transformation is likely due to progressive accumulation of genetic changes over time. Right? So based on the histological grading, mild dysplasias have good prognosis. That means there is a very high chance of, if the patient stops the habit at this point, then the lesion can reverse and the patient has less risk of developing oral cancer. Whereas moderate and severe epithelial dysplasia, they have fair and poor prognosis because the genetic changes, genetic damage that has taken place because of the exposure to carcinogens is more than that in mild dysplasia, and there is a fair risk of. So, to give you a perspective, in Malaysia, the prevalence of oral cancer is very high among ethnic Indians, followed by Malays and then Chinese. The occurrence of oral potentially malignant disorders again is high in ethnic Indians, followed by indigenous populations of Sabah and Sarawak. Now, according to the National Cancer Registry, mouth cancer can be ranked as the seventh and the third most common cancer for the ethnic Indian males and females respectively. Oral cancer is the second leading cause of death due to cancers among Malaysian males in Malaysia, according to the Ministry of Health. Okay, and the risk habits in Malaysia for patients who develop oral cancer is number one, the highest is beet liquid chewing, which is seen in 59.9% of the patients, followed by smoking 36.1% and alcohol consumption 35.2%. The most common site where oral potentially malignant disorders or precursor of cancers can be seen in Malaysia has been identified as buccal mucosa, 36.2%, followed by tongue, 33.8%, gingiva, 21.5%, the palate 4.6%, and the floor of the mouth 3.8%. Okay, so with this introduction to the red and white lesion, I hope you have understood the concept of why the mucosa appears red or white, the different reasons for a white appearing lesion in the mucosa, what is the concept of oral potentially malignant disorder, why is it so important, what would it look like microscopically when we biopsy oral potentially malignant disorders such as leukoplakia, which is quite common, and what would be how is it microscopically identified, how is it graded, how is dysplasia graded, and how does that affect prognosis. Okay, so this is the aim of this lecture. I hope you have understood it. We will again rediscuss some of this as case-based learning when we look at the practical session that will be done on Google Classroom. All right, so thank you very much. Have a nice day.
Next, let's come to the mammoth, which is oral lichen planus. There's a lot to talk about this disease. The term lichen actually originates from a symbiotic organism which is composed of algae and fungi. This is a picture of oral lichen planus, which is seen on sorry, not oral lichen planus, the term lichen, which is used for these algae or fungi which grow on trees or stones, for example. The etiology of oral lichen planus is largely still unknown. So it is believed to be an immune pathologic lesion with auto-reactivation of T lymphocytes. Stress plays a very important component and is also associated with hepatitis C virus. The most important about oral lichen planus is the fact that it's a potentially malignant disorder, and hence it needs to be dealt with carefully, and the patient needs to be on follow-up for a long duration. So 0.5 to 2.2% of population is affected. If you look at this number, it might seem very small, but as a dentist, it's important for you to understand that many of these patients don't really come to you with the oral lichen planus as a first sign or symptom, and many a time it is you who are actually diagnosing it in the first time. There's a high female predilection and the mean age is around 55 years. Now this is around the age of postmenopausal age. So that's why if you notice there's a very high tendency for females to be the patients whom you're likely to see in your clinic. The clinical features of oral lichen planus, there are generally 6 types of clinical features. Don't confuse them for histopathological features. These are classically clinical features, right? So you have both red as well as white appearing oral lichen planus. They are classified as reticulum or reticular type, where you see white striae or in an annular pattern. Papules, which are white, small white dots, also called as papular. Plaque-like, don't confuse for plaque-like lichen planus with leukoplakia. That's entirely different. Leukoplakia is a different disorder. We're not talking about it yet. So if you've noticed, I've put the first 3 in black and the rest in red. There's a reason to this. The bullous, erythematous or atrophic and ulcerative are extremely painful conditions, and hence they are symptomatic. The reticular, papular and the plaque-like are generally asymptomatic. Now, it's not necessary the patient should always manifest with only one. You could have a combination of all of these at the same time. And it also indicates the disease is progressing. Now, as a rule, generally Lichen planus appears as reticular first and then only, or papular, reticular papular first and then only you see the rest of the types. So that means if it's moving from in this direction from white to red, you understand that the disease is progressing or severity of the disease is progressing. Right. So, moving on. Let's look at some pictures of how Lichen planus appears in the oral cavity. In this is a picture of a patient with bilateral reticular form of Lichen planus. You can see the striae. You've learnt in year 3 that these are called as Wickham striae. Okay, you can also see that there are reticular form of lace-like pattern of white appearance on the lips of this patient. This is the papular form of oral Lichen planus, where you see small white dot-like appearance, but somewhere here in the corner you see that there is also some sort of reticular network-like pattern. This is a case where you're seeing reticular type, white lines, striae along with erythematous areas. So this is an example to show what I just mentioned earlier, that the disease is probably progressing from starting off with white and then progressing with red areas. That means the patient is initially asymptomatic and turns symptomatic later on. Now, how soon will the patient go from white to red, or white to mixed to red is very difficult to say. It could be months or even years. Examples of erythematous Lichen planus, you would see that there are white areas and then there is central redness here. Similarly, here also central redness with the surrounding white areas. So this is the appearance of erythematous Lichen planus. Now, this is a very interesting terminology, Dischomatic Gingivitis. This is not a diagnosis, but it's a clinical feature where you see erythematous areas mixed with white striae, erythematous areas mixed with white striae, and generally seen on the gingiva. That's why the term Dischomatic Gingivitis. The gingiva is sensitive and peels off easily and is extremely painful condition. So the patient comes to you saying that, doctor, I'm not able to brush my teeth. When I brush my teeth, I end up with a lot of pain and I feel that my gums are peeling off. Please help me. What am I supposed to do? Right? Next is ulcerative Lichen planus. So you can see that there's a large ulcer here, on the lateral border of the tongue and the buccal mucosa. You will also, if you observe carefully, you will also see that there are some striae seen on this part of the tongue and this part of the mucosa here. Some striae here as well. So like I told you, the reticular areas should be visible some part of the oral cavity to call it as oral Lichen planus. Otherwise, you can easily confuse this appearance to ulcerative disease. Had you seen this patient only with ulcers, that means you've not seen this patient in the earlier form of the disease, but you're seeing the patient in an advanced form of the disease. Now, plaque type of Lichen planus is very, very similar to homogeneous leukoplakia, very difficult to make out. But one giveaway would be that probably, the patient could be female, or another giveaway, a clue to the diagnosis, which leads to the diagnosis, is the fact that Lichen planus is always bilateral. Right, so this is a case where the plaque type of Lichen planus is also developing ulcerative areas. If you notice in the corners over here, so suggesting disease progression. Now, Lichen planus actually is a dermatological disorder. There are skin manifestations in 15% of cases which start off as oral Lichen planus. Pruritus, erythema, violaceal papules. Violaceous means violet. Papules and plaques are seen. This is appearance on the skin. There's a very interesting terminology called as Cobner's phenomenon, which means that when skin gets traumatized, for example, scratching, you end up getting a new lesion. Right? It can also happen in the oral cavity because there's constant trauma in the oral cavity during eating, during brushing. It might just aggravate the oral Lichen planus. So, does that mean that patients cannot eat and brush? Well, yes, they have to be careful while doing that, and it could be quite painful. Genital mucosal lesions are also seen in 20% of the women who manifest with oral Lichen planus. So, it's important to ask the patient if they have symptoms elsewhere. As a dentist, when you're looking at a patient and you're suspecting oral Lichen planus, it's important to also ask the patient if they could be having any skin lesions or any genital lesions. So, the diagnosis of oral Lichen planus, to establish clinical diagnosis, it's important to see reticular or papillary lesions. Generally, lichen planus lesions are bilateral. Erythematous lichen planus can occur as Dischomatic Gingivitis without white stripe. That means it could be completely red gingiva. And in these cases, you might need a biopsy for diagnosis if you're clueless as to why is it so erythematous and you're having other differential diagnosis in mind. Biopsy is important and should be taken from gingival pocket in this kind of situation. But if the lichen planus is on the buccal mucosa, then you would want to take a biopsy from the buccal mucosa. So that's about diagnosis.
Okay, so coming to the histopathology of oral lichen planus, now that you know the clinical features and the presentation, specifically if there is a clinical oral lichen planus, we do advise for a biopsy, specifically to rule out, first of all, to confirm the diagnosis, and second of all, we know that lichen planus comes in as oral potentially malignant disorder. Thus, it's mandatory for us to do biopsy in order to rule out any pre-malignant changes. Right. So the picture here clearly shows us the histopathology of oral lichen planus. So there are three pathognomic features that we actually see. Number one is hyperparakeratosis. So what do you mean by hyperparakeratosis? It means that there is parakeratinization that is seen on the surface of the epithelium. Okay, so when there is parakeratinization that is seen, basically we do see keratin with remnants of the nuclei. That's why you are actually seeing the bluish dots along with the keratin on the surface over here. Okay, the second feature is sawtooth shaped appearance of retipex. That is, there are pointed ends of the retipex that are noted. If you look at this over here, if you look at this over here, if you look at this, as per the arrows over here. And the third most important feature is a sub-epithelial band or lymphocytic infiltration. So these blue dots that you see here, all these dark blue dots are basically inflammatory cells which are primarily composed of lymphocyte. So these lymphocytes are basically actually attacking the antigens, the autoantigens in the basal layer of cells, and thus giving rise to
So this is a picture of lichenoid reaction in pointed out in yellow. You can see here that it looks white in the outside, red in the center, and some grayish purple areas here. Very difficult to make out from lichen planus. Looks exactly like lichen planus. But the only difference here is that there's an amalgam restoration which is on the buccal surface of this molar here, and another one here, which could be the reason why this patient is having a lichenoid contact reaction. So the lichenoid spectrum involves oral lichen planus, lichenoid contact reaction, lichenoid drug eruptions, and lichenoid reactions of host versus graft versus host disease. So we're not going to the entire details of this. What the slide is trying to, case is aiming to get you to understand is that the difference between the two diseases. Right. So when we're talking about treatment of oral lichen planus, our primary aim would be to reduce symptoms of the patient. Right. So it's impossible to completely cure the patient. The only thing that we can do is to reduce the symptoms of the patient. Right. So we still don't have a complete cure for these patients. So if the patient is asymptomatic, we wait and watch. So literally you're waiting for the patient to develop symptoms, and that's the matter of fact. Primary treatment of oral lichen planus is steroids. Now, for oral lesions, we would always start with a topical steroid, and depending on the severity, either in the form of a mouthwash or a gel, minimum of 2 to 3 times a day application for at least 3 weeks. And then you taper the drug for 9 weeks. When we were talking about tapering of the drug, I'm taking you back to your pharmacology days, which means that steroid is can cause changes to the adrenal cortic complex. So that's why it's important that when the patient is put on steroids, you need to withdraw the patient from steroids slowly, and that is what is called as tapering of the drug. Right. So generally you can't have oral lichen planus patients being treated for a few weeks and that's it. They get treated and stop. It doesn't happen that way. Most of the times the patients are on long-term follow-up, and they need to be followed up for quite some time to see that the patients don't develop any other lesion in the site, or the lesion is not progressing further, and you would want to see that the patient is symptom-free. Parallelly, treatment of fungal infection is important because we know that steroids, they cause local immune suppression. So when you have local immune suppression and anti-inflammatory action in the oral cavity, there is pain relief, yes, but along with it, the opportunistic infection like candida organisms tend to thrive and grow. So to avoid fungal infection, it's important that you simultaneously treat the patient with fungal infection for fungal infection, so that he or she doesn't develop fungal infections in the oral cavity. Oral hygiene should be optimized before we start off steroids, so it's a good practice to do a scaling before you actually do put the patient on steroids. But sometimes you're looking at the patient in a situation where he's already very symptomatic, and hence you might want to do these simultaneously. Secondary phase of treatment, if the steroids are not working anymore, would be topical cyclophosphamide, tacrolimus and retinoids. Of course, the patient should be medically fit to receive these medication. Most important thing is oral lichen planus is a potentially malignant disorder, and hence it has a malignant transformation rate of 0.2%. So it's important that the patient's symptoms are under control and the disease is monitored over a long period of time. What it actually means is that if in case you're seeing changes, then it's important to take a biopsy. Moving on, let's look at another white lesion, which is oral submucous fibrosis. Again, you must have dealt with it in detail in oral pathology. Let me give you a more clinical point of view for this topic, right? So these are some pictures of a patient where you can see that there are white marble-like appearance of the lower labial mucosa here, as well as the entire buccal mucosa. This is what we call as marbling. One thing you must very important to observe is, first of all, there will be a lot of clues in the oral cavity to suspect that this patient has been using tobacco, like the stains that you see on the teeth here, classical tobacco or betel nut stains. OSMF is a clinical white lesion with translucent marbled white appearance of mucosa. There is restricted mouth opening and tongue movements. Patient generally has associated tobacco chewing habit, especially what we call as pan, which is betel leaf, and betel nut, which is the Penang nut, tobacco powder, slake lime and spices. Also available, commercially available flavored tobacco called gutka. This habit is especially predominant in the South Asian subcontinent. That is generally patients who are coming from India, Pakistan, Bangladesh, Sri Lanka, and even Taiwan. So there is and Myanmar. There's a high tobacco consumption in these areas, and you will see that many of the patients use these flavored tobaccos or pan. But this is a potentially malignant disorder, and the malignant transformation rate is 7.6%. The differential diagnosis of the clinical appearance could look like amyloidosis, generalized fibromatosis, oral manifestations of scleroderma, or lichen planus, or even anemia, because the pallor or the white area, a whitish appearance, could look like anemia. In fact, many of these patients have coexisting anemia because of poor malnourishment, because they constantly keep chewing these tobacco products, which reduces hunger. And in the process, they eat lesser nutritious food and develop anemia.
Okay, so moving forward, I would like to add what Dr. Larry just mentioned. So these are images of the etiological factor here. Let me get my pointer on here. So this is what is called as pan. Pan basically is the word which describes a leaf. Here in this case, this is the betel leaf. This piece of brown color material that you see in the leaf that they have put in is the betel nut or the areca nut, the Penang nut. Okay, and these are all the various spices that they put in. They make it into a quid, and these patients chew this for long hours. Okay. The second most important etiological factor, which is been attributed to oral submucous fibrosis or OSMF, is gutka, and these are the various brands that are actually available in various parts of the world. And these are some pictures from Southeast Asia show you in the next slide that on one of these packets, if you look right behind, the ingredients that is contact that mentioned is betel nuts, catechu, tobacco, lime permitted spices and flavors, and added flavor. Okay, and there's a clear statutory warning that mentions that chewing of tobacco is injurious to health. Despite that, people still go ahead and use these products. Right. Now, over the years, the pathogenesis of oral submucous fibrosis has been um, discovered by researchers, and many researchers have been able to attribute the pathways that actually lead to the clinical features that are seen. Here in this case, here I am trying to show you the pathway here. Number one, at the outset, areca nut has been identified as the carcinogen. It is recognized by WHO as a carcinogen, and what it does is when the patient actually chews this areca nut, when it mixes with saliva, it interacts and produces alkaloids, flavonoids, copper, which is present in the gutka, and the fourth component, which is constant chewing that takes place, that leads to this transformation. So we'll look at it one by one. The alkaloids, what they do is that they lead to the release of arecolin, which hydrolyzes and enhances the addition of which causes hydrolysis, which is enhanced by the lime is calcium hydroxide basically, which leads to arachidine formation, pronounced proliferation of the fibroblasts, increased collagen formation, and thus leading to one aspect of the oral submucous fibrosis. So if you look at the term oral submucous fibrosis, that means there is something that is taking place submucosally, and that change that is taking place is leading to fibrosis. Okay. So second component, which is the flavonoids, again leads to tannins and catechin production, which inhibit collagenase, which reduce the breakdown of collagen, thus increasing the fibrosis content. Similarly, copper increased concentration of soluble copper in the saliva because of the areca nut, and the components of the gutka lead to upregulation of lysyl oxidase activity, leading to insoluble collagen formation, thus again increasing fibrosis. So what happens when this fibrosis component under the epithelium increases? It leads to juxtaepithelial hyalinization, which I'll show you in the next slide, which leads to vasoobliteration. That means the blood supply reduces, right? This reduction in blood supply leads to depletion of glycogen, muscle fatigue and degeneration, musculofibrosis and scarring, thus leading the patient to pronounced limitation of mouth opening, right? So this reduction in mouth opening, which is taking place because of the fibrosis that is taking place, is happening because of this pathway. So these three components, which are primarily released by the areca nut when it's chewed, lead to fibrosis in this particular mechanism. Now the constant chewing that takes place when they chew the betel quid or the gutka leads to muscular contraction. Okay, basically there's overactivity of the masticatory and perioral musculature, leading to again depletion of glycogen in connective tissue, leading to muscle fatigue and further enhancing the fibrosis, right? So this is the uh, pathogenesis of oral submucous fibrosis. That is how the fibrosis component is taking place. Now, as has been mentioned, why are we concerned about oral submucous fibrosis? Is because it is described as a potentially malignant disorder. So what does that mean? It means that once a patient develops oral submucous fibrosis, he develops a very high risk of the epithelium undergoing malignant transformation into squamous cell carcinoma. Okay, so with the background, let's see how the histopathology will look when you do a biopsy for these patients. Basically, I have here put in a microscopic slide and also a diagrammatic representation with labeling over here. Okay, we'll take this one by one. So I hope you do recall the normal epithelial tissue, how it would look. Here in this case, we clearly see a flattened epithelium, right, which reduced thickness. So this is called atrophic epithelium, right? This is called atrophic epithelium without ready ridges. Okay, so without ready ridges. So I'm trying to correlate it with what is labeled over here. Right now, the area where the regular normal ready ridges should have been seen, now you are seeing this pale pink color connective tissue. Now this pale pink color connective tissue, that the change in the connective tissue is described as hyalinization. Hyaline means glass like. Okay, so juxta-epithelial hyalinization means hyalinization or glass-like tissue formation under the epithelium. Okay, so this pink color, pale pink glass-like change is the juxta-epithelial hyalinization. So these are two important features that we see. The third important feature is the increased number of collagen fibers that you see in the connective tissue. Fourth is these blue dots, which is the chronic inflammatory cells, focal inflammatory cells that you see. And the fifth, which is not very clearly seen on the slide but is uh, still visible, is the muscle fiber showing degeneration. Okay, so these are classical pathognomic histopathological features for oral submucous fibrosis.
This is a old clinical staging given by Pinberg. I've chosen to use it here because it still holds good. So, and this is a simpler form of clinical staging, which divides it into stage 1, 2 and 3. There have been various other forms of more complex and more detailed staging, but for ease I have chosen Pinberg's classification. So the first stage is stomatitis, where you see erythematous mucosa, vesicles, ulcers, and sometimes pigmentation and petechiae. This stage is generally missed by many clinicians because the patient doesn't really present to you at this stage, or it is probably overlooked. The fibrosis or stage 2 is when symptoms start to set in, where you actually see blanching of oral mucosa, and when lesions are a little older, you can palpate fibrous bands in the buccal mucosa and around the mouth opening or lips, like the picture you've seen previously, resulting in a mottled, marble-like appearance of the mucosa because of the vertical thick fibrous bands running in a blanching mucosa. So the word blanching is used. It's a very typical clinical sign seen in oral submucous fibrosis, is when you actually press the mucosa with your fingers, you will see the white area spreading wider, and that's what we call as blanching. So specific findings include the following: restriction of mouth opening, which is seen, it is called as trismus, stiff and small tongue, blanched and leathery floor of the mouth, fibrotic and depigmented gingiva, rubbery soft palate with decreased mobility, blanched and atrophic tonsils, sunken bud-like uvula, also called as hockey stick uvula, sinking of the cheeks, not commensurate with age or nutritional status. That means the cheeks look sunken because they're so thick and fibrotic that when the person actually puffs his cheek, they don't even puff out completely because the cheeks have lost their resiliency, and suppleness and now are very thick and stiff and fibrous. So that's one of the tests that you ask the patients to do: puff out their cheeks, and you will see that this cheek is actually sunken. The stage 3 is sequelae of OSF, which is either leukoplakia, basically potentially malignant disorders developing in OSMF, and this is seen in about 25% of individuals. Speech and hearing deficits may be there because of fibrosis of the tongue and the eustachian tubes. So this is an example of leukoplakia. If you see, there's a whiter thickened area over here and some few red areas here in this lady who has difficulty in mouth opening and a very narrow oral aperture, which suggests progression of the lesion. Now, treatment of OSMF is very complex. Again, I have just tried to summarize them into these headings. Important thing to remember is, again, asking the patient to quit habit. Now, one thing about treatment of oral submucous fibrosis is, first of all, it's very challenging. Not only challenging for the clinician from the point of view that the lesion is changes that happen are irreversible because of the juxta-epithelial hyalinization and the amount of collagen that is laid down, but also from patient compliance point of view. So many of these patients end up not complying to treatments and are lost to follow-up because the treatment and management is long-term, lifelong, and sometimes not very successful. So the pharmacological methods of treating would be giving fibrinolytic preparations like hyaluronidase, collagenase, colchicine, steroids, which are anti-inflammatory and reduce fibroblast proliferation and collagen deposition. They can be either topical or injected into in and around the area where the lesions are seen. Intralesional injections can be given. Placentrix, which is an aqueous extract of human placenta and which stimulates regeneration and recovery, antioxidants in the form of vitamin E, A and C, and others like lycopene and alpha lipoic acids, pentoxifillin and levamisole. These are all newer drugs which have been tried, and some of them have been really successful for some cases. There are surgical methods or non-pharmacological methods which have been used, like the surgical splitting of the band and trying to open up the oral mucosa by force. But what happens is when you actually surgically do this, sometimes reverse fibrosis or more increased fibrosis can happen. Physiofibrolysis using microwave diathermy and physiotherapy, and laser therapy of the bands. So some of these patients actually in some cases there is success. So it depends from case to case how treatment is instituted for the patient.